Today, it's an honor to have with us Dr. Daniel. Dr.Oh is a pioneer and a major researcher in the area of robotic surgery of the thorax. So lung and esophagus mainly. And he's going to also talk about the newest technology involved in bronchoscopy, which is phenomenal. These things are now being done at St. Jude. He has been on the faculty of the USC School of Medicine, and he's heavily involved now with the development of the latest technology in bronchoscopy and robotic surgery of the chest. So please welcome Dr. Daniel Oh.
Thank you, Dr. Lawler. Dr. Lawton. It's a pleasure to be here. I think this is my second time I've been out. I actually see a few familiar faces. As mentioned, I'm going to focus my talk on lung cancer. I do also do esophageal surgery as well. And we're going to talk about screening and what we're doing in terms of surgery nowadays. Now, a little bit about me. I finished my training in cardiothoracic surgery. I did my general surgery training at USC and my cardiothoracic training at Harvard. I came back to USC on faculty in 2010. I've been doing robotics since 2011. I've been at St. Jude since 2014, so 4.5 years. And nowadays, I also spend a lot of time, as mentioned, working with a company called Intuitive that makes the robotic system that we're going to talk about, primarily involved in research and also in training technology, how we teach surgery better to other surgeons around the world. The scope of the problem is this. There are nearly or over 250,000 patients every year diagnosed with lung cancer in the United States alone. This is a worldwide problem. Smoking occurs everywhere. It's estimated over 2 million cases a year. And so this idea that just because we sort of have decreased the incidence of smoking starting in the 1950s until now, we're still seeing the effects of that. There's a lag between the time that you start to reduce smoking in society and the actual decrease in the amount of lung cancer that we'll see. It's estimated there's about a 20 to 30 year lag. Now, lung cancer by itself is the #1 cancer killer in the United States. It is responsible for more deaths than prostate, breast, and colon cancers combined. So if you think about how much attention is given to these other cancers, the impact of lung cancer on society is actually profound. But it doesn't tend to get the same amount of attention. I wouldn't try to state that one cancer is more important than the other, but I do think that the amount of resources that are allocated proportionally to lung cancer is really under what it should be if you look at the different types of cancers. And if you look at the different types of cancers, the reason I think that this is the case is that in breast, colon, and prostate, and other types of cancers, we've been making a lot of progress. So we have a lot of survivors. And so survivorship is very important, and that's driving public awareness and nonprofit organizations that focus on that kind of thing. But lung cancer, until now, has not really seemed to be making strides in survival. And so we don't have this population of lung cancer survivors who are mobilizing our colleagues and our friends and family to pay more attention to this disease. In addition, it has a stigma because people think, well, it's associated with smoking, and well, in that case, it's that person's responsibility. But in actuality, the fastest growing lung cancer nowadays is in our non-smoking never smoking patients. And this is happening worldwide. And we don't actually understand why that is occurring. If you look at the survival rate over 5 years from the time of diagnosis, it's not great, almost 20%. It's actually the first time in about 30 years that that number has started to go up. For about 30 years, the number has been 15%, and it hasn't changed from the 1970s, despite all these new drugs and all these new therapies. And the reason for that is it's diagnosed too late. If you diagnose lung cancer early, it's actually a curable disease. If you diagnose lung cancer late, it's very hard to manage. Now this number, 5% survival, is also getting better. That's actually what's carrying the overall number higher. And what will be interesting is Dr. Park's talk next week. He's a medical oncologist, and he'll be able to speak to some of the drugs and immunotherapy treatments that are revolutionizing this field. Now, if you look at lung cancer as a whole, and you just break out at what stage are people diagnosed in the United States, it's very clear that the biggest stage, or the biggest piece of the pie, here at 57%, is this distant stage. And if you think about what that means is that the cancer has already left the lung and has gone even beyond the lymph nodes and has spread to other parts of the body, like the brain, the bones, liver, etc. So 57% of lung cancer, when diagnosed, is already spread outside the chest cavity. Localized, that means just in the lung, is 15%, the dark purple. And then regional means it's spread outside the lung, but only into the lymph nodes, which is like the sewer system of the body, where things can get caught up as they're trying to spread. So if you look at localized and regional and add those two up, it's about 37%. Those are the people, the patients that we can offer surgery potentially. But once it's distant, which is 57%, surgery is not an option. So to move the needle in terms of improving survivorship, we need to get rid of the distant metastatic cases. We need to diagnose people earlier. And so more than any fancy technology or multi-billion-dollar drug, diagnosing a cancer earlier is going to make the difference more than anything that we can develop on our own. And we've seen that in breast cancer, colon cancer, prostate cancer. It truly has changed the outcomes of our patients in these other diseases. And we need to start to do that in lung. So what does screening mean? Screening is a medical term, but it's very commonly used in the lay world. It means testing for the presence of a disease or a condition when that disease or condition is asymptomatic. So it means not when you have pain or coughing up blood or things like that. It's when you're walking around perfectly fine, feeling perfectly fine, finding a cancer. And so that's really what screening is about. Now, unfortunately, lung cancer doesn't typically present itself in terms of symptoms until it's quite big. And the reason for that is each lung is basically a bag of air. And so if you imagine a little growth starting to grow in size over time inside a bag of air, you're not going to feel anything. You're never going to know. It's different than if it's in your bowel and it blocks the bowel, then your GI tract stops working, or things of that nature, or when a cancer is superficial near the skin and you could feel a lump. This is not something you could feel because of the rib cage. So this is really the perfect disease to develop good screening, because we don't want to wait until people are having symptoms. We obviously want to catch the cancer early, as I mentioned, because that's when the chance of cure is highest. A key part of screening from a public health perspective is that if you detect a cancer early, you must show that detection of that cancer reduced the mortality of that disease. So finding a lung cancer in and of itself does not define successful screening. If you find the lung cancer early and then you're able to act on it, and then the outcomes of those patients is better than those who didn't get screening, then the screening is considered successful. The reason I bring this up is that there are two scenarios where screening is problematic. Number one is that the cancer itself is not harmful. Kind of an odd thought, but there are cancers that we can detect which probably won't kill you. Prostate cancer is one where there's a lot of controversy now about, well, even if you detect it, many of them can just be watched and you don't have to do anything and people can live the rest of their lives. So if you think about that in terms of screening, finding a cancer early that's not going to kill you, that's not really successful screening. The second scenario is when a cancer is on the opposite end of the spectrum, where it's super aggressive, where even if you find it early, the treatment is not successful and the outcome is going to be the same. A very nihilistic or pessimistic view, but lung cancer actually falls into that category until now. So these are the two scenarios where screening has some issues. And that's why until recently, 2011, screening for lung cancer was not recommended, because the medical profession could not prove that finding lung cancer early would lead to better survival, mainly because the treatment was not that great. And so even when we found it, we weren't moving the needle in terms of survival. Now, the way we screen for lung cancer is because it's in a hard to access area of the body, we need to use imaging. There are two ways we can image the chest cavity. On the left-hand side is an example of a chest X-ray, which many of you have had throughout the course of your lives. The technology has been around for probably over 100 years. It's relatively crude. As you could see, the lungs are black. You could see the ribs, maybe not from the back. You could see the heart in the middle, the spine running down the middle. And if there was a small nodule, a small growth, it would be very subtle. It would not be easy to find. On the right-hand side is a CT scan, computerized tomography, which was invented in the 70s and refined in the 80s. It's more like a three-dimensional way of imaging. So it's going to scan you up and down, and then the computer will allow you to collect all the images together so you can go up and down and look in 3D. What you're seeing is one slice of a CT scan, just one slice as if you were going through one at a time. We do these slices nowadays every 2 millimeters. So to do the chest cavity, we're talking about over 100 images. You're looking at the same picture, but from a different perspective. Again, the lung is black. Now you're seeing all these little things, these little white streaks and dots on the lung. These are all blood vessels. You can also see airways, which are the dark black within the gray. The heart and the blood vessels are white, and then the soft tissue and the ribs are surrounding it. We can change the algorithm of how we would look at the CT scan to focus more on lung tissue or focus more on soft tissue, like the muscle and lymph nodes. In this one, we're looking at the lung. So I mentioned to you that lung cancer screening had not been approved until 2011, even though we've had chest X-rays for 100 years and CT scans for 40. And the reason is we could definitely find cancers earlier, even starting in the 70s and 80s. There were clinical trials that showed we could find it earlier, but the outcomes were the same. So really, the technology for imaging hasn't changed that much. It's the treatment that's changed. Now, we weren't sure which is a better way to screen. Chest X-ray is cheaper, it's easier, it's faster, but CT scan seems like it gives us better resolution, more detail. Which one is better? So a trial was done. This was actually sponsored by the federal government. It's called the National Lung Screening Trial, NLST, and it compared chest X-ray and CT scan in people who were high risk for lung cancer. And we defined high risk as people who smoked a lot, and we'll go through some of the details of what exactly that means. This was not everyone walking off the street who got a CT or a chest X-ray, so we're already thinking about people who are at higher risk. The interesting thing about this trial is that it compared an X-ray to a CT scan, when in fact, at that time when this trial was conducted, the standard of care was doing nothing. So you have to think about the results of this study in that context, that we're comparing X-ray to CT and the differences between that, but not comparing it to doing nothing. So the magnitude of benefit is going to be even greater than what we see. In the study, which was an extremely well-conducted study, nearly 55,000 people across the US enrolled. Imaging, either X-ray or CT, was randomly selected based on an algorithm. As some of you may know, when we do a randomized controlled trial, we don't let the patients choose or the doctors choose so that we eliminate bias. And there's usually a software that randomly allocates which way the patient's going to go. And the protocol was that you get one of these imaging modalities once a year for at least 3 years. The reason for that is the thought process was if you just do it once and something new pops up, you'll miss it. And if you just do it once and you do see something, it may be benign, and the only way to know is to follow it over time. The results, as I mentioned, were published in 2011, and it showed for the first time in medical history that lung screening with CT compared to chest X-ray reduced the number of deaths attributable to lung cancer. So we're not just detecting these things earlier, we could actually finally prove that by finding it earlier, you can reduce the mortality and increase the survival. And that's compared to chest X-ray. So compared to doing nothing, it was definitely a benefit. The relative benefit compared to chest X-ray was 20%. So the survival was 20% better in the people who got a CT scan. The interesting thing is you also got better survival from other causes of death, because as we were scanning people, we would see abnormalities in the heart and in the blood vessels, like calcium deposits in the coronaries or aortic aneurysms. And then the doctor could then, have the patient see a vascular surgeon or a cardiologist and intervene. So there was a byproduct to screening for lung cancer. And because this was the first time it showed that it saved lives, it was finally approved by Medicare. But this process took a while. It took about 3 years, actually, from the time the trial finished until Medicare approved it. And now private insurances will cover it as well. A few words of caution. When I say CT scan, this is not a regular CT scan. These are low radiation CT scans. The reason they have to be low is that you have to have it once a year. And so the thought process is we don't want to irradiate people and start to cause other problems. The radiation in these scans is 1/5 the radiation of a normal CT scan. The other benefit is you don't need an IV injection of medicine. Many CTs, some of you in this room may know, if you get a CT with contrast, they call it, you have to get an IV. For the lung, you don't need IV contrast. So it's lower radiation, no IV contrast. It's quite easy to do. The most important thing is that 1/4 of patients who had a CT scan had a nodule or some kind of growth in their lung. So if you think about it, 1 out of 4 people who got a CT had something wrong or something abnormal in their lung. But when you track these nodules over time, only 4% of these were cancer. So that shows you what a mess people's lungs are. I mean, when you smoke for a long time and just live in the environment we live, your lung is exposed to everything as you breathe in and out. All the dust, the particles, the pollution. And over time, your lung is a battlefield of everything you've lived through over the course of your life. So you're going to get scars, you're going to get little things that were infections at some point that got walled off. So even though 1 in 4 people had an abnormality, most of these, nearly all of them, were benign. And so that really is the challenge, in that 96% of these lung spots are false alarms. And that's very important to know as a patient, because if you sign up to get lung screening, or someone that you know gets lung screening, that can induce a lot of anxiety. That, oh my gosh, you know, the report said there's a spot in my lung. Well, by probability, it's most likely going to be benign. But still, it's anxiety provoking, because if we leave it inside your body, but we still don't know for sure what it is, you know, people aren't as comfortable about that. The other important thing is what we found in the study is that the repeat scans were very important. And so this idea that you can just get a scan and then be done is really not true. Many of the cancers detected in the trial were found over time. They weren't found on the initial scan. Now, a little bit on who is eligible for lung screening. There are a few factors that come into play. Number one is age. Age was 55 to 77. Now, this is always controversial, especially the upper limit of age, because I will tell you, we are treating people with lung cancer into their low 90s. You know, the oldest patient I've operated on is 86. You know, the median age at which lung cancer is diagnosed in this country is 70. So, you know, when they made the upper limit 77, they actually made it 75 originally in the trial, but many of the medical societies were challenging Medicare to raise it up to 80. And they compromised and went to 77. The reason that they chose that number, unfortunately, is it's a public health resource allocation issue. You know, so when you're the government and you're responsible for the care of a population, you have finite resources. You need to, you know, dole out the money for, you know, what's going to have the biggest bang for your buck. And so they felt that limiting to 77 was the way to do it. It's debatable. The other point is the smoking history. I mentioned to you that many lung cancers nowadays are found in people who don't smoke or never smoked. But to be eligible for screening, as covered by Medicare and by insurance, you have to have smoked a lot, because that's the way the trial was set up. And in the trial, you have to have smoked 30 pack years or more. A pack year is a medical calculation, very easy to think about. But if you smoke 1 pack a day for 1 year, that's 1 pack year. If you smoke 2 packs a day for 1 year, that's 2 pack years. So you can come to different combinations to get to 30. So 30 pack years would be 1 pack a day for 30 years, or it could be 3 packs a day for 10 years. So that's the way we think about it. Now, if you quit, you couldn't have quit more than 15 years ago. So that's another artificial sort of line that they drew in the sand. The reason for that is they felt, and based on some studies, that if you quit for over 15 years and you haven't developed lung cancer, your risk of developing lung cancer is starting to go back to normal as someone who didn't smoke. So again, it was finding a population where you're going to get the biggest bang for your buck. It was very important for Medicare that there be a face-to-face visit with a physician, a nurse practitioner, or a physician assistant to talk to the patient about lung screening, primarily because of the evidence that I showed you, where 1 in 4 people were found to have a spot in their lung, and 96% of these were false alarms. And so if you just unleash lung screening into the public and you can allow anyone to just walk in off the street and get it, people are going to be running around frozen, in panic and anxiety because they say, I have a lung spot. So we really have to spend some time to counsel people so that they understand and prepare them for what this involves. The other important point is that if the person is smoking, they must participate in a smoking cessation program that's sort of sponsored by the hospital in order to be a beneficiary of this program, a beneficiary of screening. So we won't offer screening to people who are going to keep smoking without trying to quit. Now, even with programs, sometimes people can't quit, but at least we've checked the box that they've tried. Because public health research has shown that even though lung screening is saving lives, if you actually reduce or eliminate tobacco use in this country, you will save far more lives than you will with lung screening. So it's still better to stop smoking, even if people have smoked for a long time, for decades. There are special circumstances. These are one-offs where it's not really approved by Medicare, but there are other medical societies such as NCCN, which is a sort of a consensus of specialists around the country. And there is this consensus that there are groups of people or individuals who should get screened, but they don't fall into the exact category that we just talked about. So if there's a significant family history, this has to be first-degree relatives, so your parents or your children or your siblings. Exposure to radon, especially in the Midwest. Exposure to occupational carcinogens. Now that's sort of a broad topic. There are many known carcinogens that are associated with lung cancer. I would say the one that we would be most likely to be seeing around here would be asbestos. Not because we have a lot of asbestos around here, but we don't have a lot of mining, people in Orange County. We don't have people mining plutonium in Orange County, but we've got people who used to be in the Navy. They maybe worked as plumbers. They were dealing with asbestos for the insulation. We saw a lot of this in Boston where the shipyards are. And so that is really the main thing. But the other one is at the bottom, on the right side, is radiation. So if people had exposure to radiation in their lives, a significant amount of radiation, that is a risk factor. Most commonly, I would say like lymphoma, when people were treated for lymphoma as a kid. But we're actually starting to do research in breast cancer, because breast cancer patients very commonly get radiation to the chest area. Now, it's supposed to treat the breast, obviously, but radiation can go through structures and can cause some collateral damage. And so there's some thought, some hypotheses that maybe we should be looking at breast cancer patients who had radiation to make sure that they aren't developing lung cancer. The point of this talk is really to educate all of you and to point out that knowledge is power. Despite the fact that lung cancer saves lives, less than 5% of eligible patients in this country are getting screened. Now, I mentioned to you the trial came out in 2011. Medicare didn't start covering until 3 years later. So let's say 2014. It's been a good 5 years, and we're only at 4.2% adoption. The reason behind this is there's a lot of, I would say, a little bit of hesitancy amongst doctors because people aren't comfortable ordering CT scans over and over once a year. But as I pointed out, these are low radiation scans. And so I think from the medical side, we need to do a better job educating primary care doctors. But many things in healthcare are driven by the patient. So I think if you know someone or you yourself, falls in the criteria or meets the criteria, then this is something that needs to be brought up. And we actually brought some of the questionnaires that we use in our clinic that we put at the back that you can take on your way out. It's very important as a patient to know that when you get a CT scan for this purpose, it's low radiation because this is something that's not quite familiar to primary care doctors. The other thing is abnormal results, because 96% are false positives or false alarms. We believe at St. Jude that all of these abnormal scans need to be reviewed by a team of doctors who are specialized in the lung. We don't want just the radiologist to give the report, because oftentimes the radiologist is giving a broad and vague report because they don't know the history of the patient. They've never met the patient. They're just looking at an image. They want to cover their rear, so they'll say all sorts of things like could be this, could be that, and then they'll recommend basically nothing that makes any sense and say you could follow it up or you don't need to, depends on the situation. That's typically how a radiology report comes out. So we actually believe that these have to be reviewed by a team of doctors so that we can make a firm recommendation what the next step should be. We also don't want to subject people to unnecessary procedures. If we know that 96% of these lung spots are going to be benign, we don't want to start whacking these things out with surgery or putting needles in them, causing complications when they're not needed. So I think we're really trying to be mindful of being responsible. Now a little bit on lung nodules. Lung nodules, a nodule is a medical term for a spot or a little growth in the lung. There are different lung nodules. I've shown two examples of sort of the two opposite ends of the spectrum. A lung nodule could be solid, as seen on the left, where it's a bright white image. It's like a ball, dense, you could cut through it and it's tissue. Or it could be on the opposite end of the spectrum, what we call a ground glass opacity. So if you think about grinding up glass and spreading it out and putting it and maybe shining some light through it, it's opaque, it's translucent. So it's not going to block the view of, it's not going to block the path of light like the moon would. So if you think about that, that's kind of how it is. It's more like a fluffy cloud, as you could see in this picture. So nodules go back and forth between these two extremes. And so there's a lot of different characteristics of nodules that help us understand which ones are benign and which ones are cancerous. The benign ones are typically old infections, walled off scars. Valley fever is very common in the Southwest. It's called coccidiomycosis. People could have been exposed at any point in time in their lives, even as a youth, and they will carry this scar in their lung forever. So that's very important to be mindful of. There are certain conditions that can cause nodules that are not cancerous, like sarcoidosis. And then there are, of course, cancers, which are less common, but these are the ones we're looking for. Could be lung cancer, or sometimes it's a cancer from somewhere else. So that's commonly a term that I hear people throw about. They say they had, lung cancer, but in fact it was a cancer that originated from somewhere else that went to the lung. So technically it's not really a lung cancer. Lung cancer originates in the lung, whereas metastatic cancers, or secondary cancers we call it, start somewhere else, like in the colon or rectum, and spread to the lung. And so that's another possibility. A very important point is that lung nodules can be safely followed. Again, this is this idea that we can do watchful waiting. It can be anxiety provoking, but if you are comfortable with statistics and probability, and we tell you 96% of the time it's not going to be anything, hopefully that's comforting. But rather than putting needles in every single nodule and taking every single nodule out with surgery, watchful waiting is the best thing to do. The Hippocratic Oath for doctors, it says, first do no harm. So that's one of the key tenets of managing pulmonary nodules, because there are complications that can arise when you start poking things into the lung, like collapsing the lung, what we call pneumothorax. Only if it grows typically, unless it starts off very suspicious looking based on the size and appearance. Only if it grows, then we start to say, okay, we need to start investigating this. We may do more scans. We have certain types of scans like PET scans that can make cancers glow. We can do a biopsy with a needle or through the airway, and we can take it out with surgery. The factors that come into play are the person's risk for cancer, what we call the pre-test probability of a cancer, the size of the nodule, obviously the bigger, the worse it is, the shape or appearance, the more solid it is, the worse it is, and the location. Cancers tend to happen in the upper lungs, so if we see a nodule in the lower lung, we may not be as concerned. We again focus on a multidisciplinary team approach with a radiologist, a thoracic surgeon, myself, and a pulmonologist. These are guidelines for what doctors are supposed to do when they come across a nodule. This is just a snapshot. It's very complicated. And what I would point out is that managing these nodules is as much an art as it is a science. And what I mean by that is, if a person comes in with a 7 mm nodule and the doctor says, well, we can scan you in 6 months or we can scan you in 12 months. And you may say to yourself, well, don't you know the answer? Because aren't you the doctor? 6 or 12. It's because these guidelines are very generic. We aren't very specific in these guidelines. And that's why we feel very strongly at St. Jude that we have a committee, we review the scan, and we give a firm recommendation to the primary doctor, because the primary care doctor doesn't have time to look through all these algorithms and protocols and figure out, on page 66, this is what I'm supposed to do. So we have 2 ways of incorporating lung screening at St. Jude. The first one, which I think is sort of the standard way across the country, is your primary care doctor should do this as part of your routine preventative health care. But I've just shown you 4.2% of the country that's eligible is getting scanned. That means nearly 96% are not. So patients need to take some initiative, and doctors need to get better awareness of this. So we set up a lung screening clinic, just started this year, where we hope to take that burden off the primary care doctor, where in the 15 minutes that you get, and they have to review 15 medications and all your other health issues, they're not going to have time to go through the lung screening trial and tell you that 1 out of 4 people had a nodule and 96% of them are benign and this and that. And so I think we're trying to reduce the obstacles to screening. So the screening clinic is run by Joy Amundsen, who's our nurse practitioner. She works directly with me. And she's able to explain to you what lung screening is all about. She'll go through the eligibility criteria and make sure that you're eligible and go ahead and order the scan, and then we'll get it reviewed. The nodule program I talked about, we re-review all the abnormal nodules. So we just take that radiology report as a first step, and then we actually meet as a group. We voluntarily do this every 2 weeks at 7 in the morning before our normal work. There's no charge to the patient. We do this as a benefit to your doctors so that they can have the precise recommendation of what the next step should be. And we've done over 500 patients with this, and it's been quite successful. So in the remaining time, I'm going to transition to treatment, and I'm going to sort of break out, high level. Treatment is very broad. We're not going to go through everything tonight. Early stage, when it's limited, we can do surgery. We can also do, in people who can't have surgery, this thing called stereotactic radiation, which is a tremendous advance in healthcare for lung cancer. Advanced stage is more of the drugs, immunotherapy, chemotherapy, now biologic therapy, and then regular radiation can sometimes come into play. The difference between stereotactic radiation and regular radiation is that regular radiation, because of the collateral damage, they can only give a low dose every day. And so they have to spread it out over 5 weeks so that they don't cause too much damage to the surrounding tissue. With advances in the technology that they can deliver radiation, they can actually compress that down to 3 to 5 days. And that's what stereotactic radiation is. Not every type of cancer can be treated with stereotactic radiation, but lung cancer is one of them. So that's a very nice alternative to surgery. And when I do surgery, I use the robot. And by the robot, the trade name is called the Da Vinci. And it's called the XI. That's the model that we have at St. Jude. There are 2 levels of benefits, one to the surgeon and one to the patient. To the surgeon, the robotic system is comprised of instruments that are robotic, controlled by the surgeon. But because the instruments are robotic rather than handheld, they are extremely precise and extremely stable. In addition, the camera that's incorporated in the robot has 3-dimensional video with high definition, so we can see much better, and it's magnified 10 times. And then some of the instruments actually can give us feedback on the tissue. So if the system feels like the tissue is not appropriate for what we're doing, it can actually let us know. For the patient, in addition to the more precise surgery, which has several benefits in terms of taking out the lymph nodes, getting a better cancer operation, because we're going through very tiny incisions, typically 8 millimeters in diameter, there's less pain and a faster recovery. And because we're very precise, we feel that we can get better cancer outcomes. So this is what a typical OR would look like. Now this is fake, but this is what the setup looks like. And what you see on the left-hand side is the console where the surgeon is actually sitting. In the middle of the screen is the patient covered in the blue drape, and there's an assistant standing at the bedside. And that white thing there is the robot. And then to the right side of where you're looking is the tower, which we call the vision cart. And that's actually the computer or the brain behind everything. So the way that it works is the surgeon is not remote. It's not, sometimes people think the surgeon is far away. Actually, they're right next to the patient. And this is all connected through fiber optic cables. So the digital signal from the console, what the surgeon is doing, is reproduced exactly by the system, by the robotic arms. And you can see the little arms moving from the outside, going through these tiny little holes. There are 4 arms to the robotic system. One of them is the camera, so the surgeon actually can control 3 other arms plus the camera. So it's actually interesting working on the console. It's kind of like flying a plane because you've got foot pedals and hand controls. And so, because you're really controlling 4 different things at the same time. A little bit more in depth. The console, the surgeon is looking into this little screen. It's actually 2 screens that's making the image 3-dimensional. So it looks like 3D. And then the surgeon's controlling the instruments with these little hand manipulators. If you look through the eyepiece, you could see your left and the right eye have a slightly different image, which makes the 3D. And you can see the 6 pedals of the foot control that control different types of energy and different modes that the arms are doing, camera control. There's also a touch screen on the console where we can control and make adjustments. We can adjust the console itself. This is actually an interesting point where we can adjust the console so that it's comfortable for the surgeon. And the surgeon can sit and operate all day long comfortably in a chair without having to stoop over and strain and get neck and back problems. This is a real issue. We used to think this was kind of a superficial issue because surgeons are supposed to be tough and who cares what the surgeon is feeling as long as the surgery is getting done. But there is a projected shortage of surgeons in this country, and many people are going to retire early because of health issues. And so if we can prolong the career of surgeons through this type of technology, I think it will be better off for society. A little bit more close-up on the actual robot itself. Again, the robot is not autonomous. It doesn't do anything independently. Everything is controlled by the surgeon. Now, when we set it up, the nurse is actually bringing it in and is going to roll this patient cart into the patient. And the little cannulas, which are these little metal tubes, are put in by the surgeon through the holes, the incisions, and then the robot docks. It mates to the little metal cannulas, and that's how it controls the movement. Through each arm, we can select different instruments, and you can see these instruments going in, and the surgeon can select different instruments based on what exactly they want to do. This is the brain behind the whole thing. This is just a screen that is showing what's happening inside the body for the team so that they can see. The surgeon's obviously in the console, but you can see all these things are connected by fiber optics. The interesting thing of how this was developed, it was actually developed at SRI, which is Stanford Research Institute in Palo Alto. It's a think tank of engineers, offshoot of Stanford. It's not really affiliated with Stanford anymore. But in the 1980s, the US government gave SRI money to develop a top secret medical device that we could perform surgery in the battlefield without subjecting the surgeons to getting killed, at the front line. So the idea was you send the robot to the front line, the patient is there in the battlefield, the surgeon is at the base, and through the console can operate on the patient. And so the idea was remotely do the surgery. And what happened was the system was developed by SRI with funding by the US government. The government took a look at it. They said it's too heavy, it's not practical, and they passed on it. So then it spun off into a company which now is making the robot, now for 20 years. So that's kind of the history behind it. I'll just show you a quick preview of what's coming in the pathway. I mean, this is the newest robot that goes through one incision, a 2.5 centimeter, 1-inch incision, but it has the snake-like robotic instruments. We are not doing this for thoracic surgery. It's actually only approved for urology and head and neck, tongue surgery. But in the future, I think we'll be starting to do this type of technology, using some of this technology for lung cancer. This is a robotic catheter that is used for biopsying lung nodules. So I talked about different ways of getting to a lung spot. Well, this has a software which reconstructs the anatomy of the lung and allows the person to operate this catheter from a little control, almost like a video game. And it has this shape sensing technology where the system knows exactly how to get to where it needs to go. And the surgeon or the pulmonologist basically just drives the system. Once you get to the nodule, you put the needle and get the diagnosis. So hopefully we can get this at St. Jude. There have only been 8 sites in the country that have this so far. It just came out in the last 6 months. So in conclusion, lung cancer screening with a low radiation dose CT scan is recommended for high-risk individuals, with the caveat that you're going to see a lot of false alarms, and pulmonary nodules are very common, so we need to be prepared. Whoever is going to get this needs to be prepared. Robotic surgery can be performed when lung cancer is found early, and hopefully by finding lung cancers earlier, we can start moving the needle in terms of overall survival and start making progress. And finally, there are multiple other complementary technologies and advances that will also help with this process. Radiation, immunotherapy, biologic therapy, all of these things together with robotic surgery and screening, I think are really revolutionizing lung cancer in this world, in this country and around the world. There are some experts in lung cancer who tell me that for 20, 25 years they've been working in this space and they've never been as excited as they are today because of all the things that are happening. So with that, I will conclude and thank you for your attention. Happy to take any questions for a few minutes. Okay, so the question is, do nodules weep inside the lung? Nodules typically do not secrete anything. They typically just sit there. There are some types of lung cancer, though, that can form mucus. So they can develop mucus, and we call those mucinous cancers for that reason. The other scenario is in someone who has advanced lung cancer, where the lung cancer has gone from beyond a nodule and has gone into the chest cavity. The chest cavity is really it's an interesting structure because you've got your rib cage, and then within the rib cage, your lung is sitting inside the rib cage. But the lung is actually just floating around in there. And it's really a tiny little space where there's a little bit of lubrication that allows the lung to move. But if a cancer spreads into that space, it can start to secrete fluid, and then that space fills up with water. And that may cause this type of fluid problem, which we call a pleural effusion. Yes, so the question is, has this technique spread around the world, Europe specifically? Yes, it has. Actually, I just came back from London today because I was meeting with thoracic surgeons from Europe to discuss how research can be conducted so that they can study their outcomes in Europe, because it's actually one of the fastest growing robotic surgeries around the world. It's because the chest is such a challenging environment to operate in with the rigid rib cage and all these issues that we talked about. So it's happening, it's happening, everywhere. All right, well, good.
Okay.
Thank you very much.